Thank you, everybody, for our first initial MSHP Researcher Spotlight. My name is Paul Zhang. I'm the Executive Director of the MSHP ROE Foundation. And today we're actually very pleased and very honored to have a very well-renowned researcher come and talk about his recent article that was published recently. The title is Identifying Critically Ill Patients at Risk for Inappropriate Antibiotic Therapy, a pilot study of a point-of-care decision support alert. And author Scott Misick, who is an associate professor of pharmacy practice at St. Louis College of Pharmacy. And this is an article that was published just recently in Critical Care Medicine. So I want to thank Scott for coming online to talk to us.
Thanks for having me, Paul.
Now, there's a couple of things that I think for all of us as potential up-and-coming researchers, or even those who's interested in evidence-based medicine, about understanding this article. So, Scott, if you would be able to provide us a little bit brief background regarding the study topic that you have here.
Paul, we've done a lot of research in terms of trying to improve the quality of antibiotic administration to critically ill patients over a number of years. And one of the things that we found was we didn't have really detailed histories about our patients. So sort of that medication history from an antibiotic perspective. So this all dates back a number of years ago when one of our pharmacotherapy residents by the name of Mike Johnson took on a project that evaluated previous antibiotics exposure within our healthcare system and the impact of that on antibiotic resistance profiles. And what he found was that if you had previous exposures, sort of intuitively, you had higher rates of resistance. And that was then associated with inappropriate initial antibiotic decision-making. So what we set out to do was use our informatics systems throughout the BJC healthcare system based out of Barnes-Jewish Hospital in St. Louis, and essentially use those powerful data repositories to give us medication histories.
Great. That sounds like a great idea. So in this study, what were you looking at as your research question?
Well, our research question really revolved around whether or not we could utilize patients' data within our informatics system, put that into a real-time alert, and see if it could impact our initial antibiotic prescribing. So let me give you an example of what we did. Say a patient came into the ICU and was prescribed cefepime for a pneumonia or presumed pneumonia. As soon as that cefepime was entered into the physician order entry system by a prescriber, that then would trigger the informatics repositories to screen all of that patient's antibiotic history and microbiologic history going back 6 months. So in essence, we try and come upon any order or antibiotic the patient received and combine that with their microbiologic history. So a lot of things that we would do in a normal course of business in an ICU as a pharmacist, as a multidisciplinary team, but this was really trying to automate it and then in real time send an alert to the pharmacist that was in that area.
Wow, that sounds like a great way to kind of examine, and a very, very innovative way to kind of examine this for these patients in ICU. Now, for the audience that's hearing this, I don't know if you could briefly kind of tell us a little bit how you designed this study.
Yeah, this study was really a pilot study. It was a retrospective look at just over 3,000 patients that were prescribed cefepime, meropenem, or piperacillin-tazobactam. And like I mentioned, in real time, all those patients, over 3,000, were screened for their antibiotic history. So that comprised the retrospective cohort. And then we divided them into patients that would generate an alert, meaning they had a previous antibiotic history or a previous positive culture. And that was about 25% of patients who had an order.
Now, in your opinion, what do you think are some of the major strengths? It sounds like there's a lot of strengths, but what would you consider to be some of your major strengths in doing the study this way?
Well, what we found, and again, this was a pilot, we found that out of those 25% of patients who had an antibiotic ordered, they generated an alert. And of those, about 2.5-fold, those patients had a 2.5-fold greater likelihood of receiving an inappropriate antibiotic compared to those that did not have an alert. So you can imagine that that's quite a large number whose initial antibiotic prescription would have been incorrect in essence.
Okay, wow. So did you have to face any kind of barriers that you had to overcome to try to complete this study?
Well, I think a lot of the barriers are things that we've ironed out over a number of years, and I think that something that most institutions would have in putting something like this into place, and it's really utilizing your informatics repositories and putting them to work in a fashion that, from a decision support standpoint, can make an impact right at the point of care. And I think that's the beauty of this system. We've worked with a number of great computer programmers, a number of people that have great knowledge in information technology. And essentially what happened was, as soon as an alert was generated, a text message to either a pager or a smartphone was sent. So you can see it in this day and age. It's information that's literally accessible right in your fingertips. You don't have to log into a computer necessarily or go through all of the chart notes. I mean, this was something that was readily useful. And so I think, to answer your question, that is the major barrier, making something like this very user-friendly.
Wow. Was there any kind of limitations that you weren't able to overcome? It sounds like you went through a good amount of experience in terms of overcoming these barriers.
Well, I think the biggest limitation from the pilot is going forward. Over half of the patients that we identified that received inappropriate therapy, that could have been averted. So we're talking a significant amount of patients that could have received appropriate therapy that received actually inappropriate or the wrong drug up front. And when you receive the wrong drug, it's associated with increased hospital length of stay, increased hospital mortality in these patients that are infected. So from a limitation, it's taking that technology and actually making it such that you can communicate with the prescriber to have that order changed. So there's lots of ways to do it in institutions, whether you go through your P&T committee and sort of make it a protocol of some sort, or you just develop those relationships with physicians and utilize the powerful information to impact prescribing up front. So it's really making that transition from that automated alert to making change so that you really do have effectiveness in your whole system.
Wow, great, especially hearing a little bit about the results you're talking about in terms of appropriate antibiotics. What are some of the other key results that you saw from the study?
Well, like I mentioned, it is a pilot, so I think take-home messages I've sort of gone through is that it's a high percentage of patients that have previous antibiotic exposures. About a quarter of patients in our cohort had previous exposures. Those patients, when they did have positive cultures, those patients had pathogens that were associated with a lot of antibiotic resistance. So that in and of itself will lend you to inappropriate prescribing. And like I mentioned, patients who had an alert had 2.5-fold greater likelihood of receiving inappropriate therapy compared to those that didn't. And then ultimately, those that did have a pathogen identified, particularly a gram-negative pathogen like E. coli or Pseudomonas aeruginosa or Klebsiella pneumoniae, or even Acinetobacter and the different Acinetobacter species, over half of them, based on the information in that alert, we could have switched to a more appropriate regimen. So that's, in fact, how we're going to utilize this informatics and alerting system to improve upon that appropriate prescribing.
That sounds like some very, very interesting and significant results. What is your research group plan to do with all these results? What's the next step?
Well, I think that's always a challenge. It's translating the results of positive research like this to the bedside. And fortunately, we have a great practitioner group that we work with in the ICUs at the Barnes Jewish Hospital. So disseminating this alert real time is something that is very possible, and one that everybody's committed to doing, just under that premise that if you optimize upfront antibiotic therapy such that the antibiotics you give have in vitro activity, you're going to decrease hospital length of stay and hospital mortality. So that's our goal: disseminate this and then demonstrate that it does have a positive impact on patients.
Wow, that sounds like a great article, and it's published, and I'm pretty sure there's a lot of significant results that could be seen down the line, especially if we kind of expand this into bigger populations. I want to thank you, Scott, for taking the time to kind of talk with us and go through this article with us.
Hey, it's my pleasure, Paul, and certainly thank you for having me on. This was a total team effort, like I mentioned. Pharmacy residents in the past sort of set up the studies that led to this. We had pharmacy residents and colleagues that worked on it, physician groups, and then I certainly want to highlight the importance of the informatics group that we work with. Without them, none of this would be possible, so it really is a total team effort.
Thank you, Scott, and I want to thank everybody for taking the time to listen to our first researcher interview regarding for a Missouri researcher. Thank you, everybody.